Hey, welcome everyone to my presentation on ECG interpretation. I hope you find it interesting and I hope that it's helpful to some of you. This is going to be the recorded edition. I did do a live version of this, but unfortunately I only remembered to record about halfway through, so it didn't make a lot of sense. But hopefully by doing this revised recorded version, we will be able to kind of format it a little bit better for a recorded context, if that sort of makes sense. So if at any point anyone finds some of these topics that we cover to be kind of confusing or don't make sense, I'd really encourage you to ping me an email. I'm really happy to kind of talk people through them and try and explain them. And hopefully kind of through doing some presentations like this, I'm really hoping to create like a back and forth with staff that's ultimately kind of going to improve all of our learning. So yeah, please feel free to reach out. And I do kind of apologize if I make any technical errors. This is my first time recording a presentation like this, so sorry ahead of time for that. Just a few disclaimers. I'm not an expert on ECGs. I'm not a cardiologist. I'm not an electrophysiologist. And you're not going to be an expert after hearing one lecture from me. So rely on your clinical gestalt when you're treating patients. Please try and advocate for your patients and act in their best interests. Follow your clinical guidelines, follow the heart attack admissions criteria, and be aware of your own limitations. I think the scariest clinician is someone who's arrogant and kind of unaware of their own incompetency. So, try not to be that person. Okay. So the purpose of this presentation, it's targeted towards clinicians who do have an interest in ECG interpretation and are hoping to take that knowledge a little bit further. So there's going to be kind of like an assumed baseline ability of ECG interpretation in going forward from here. I hope that makes sense to people. Basically, I think if you're looking at this presentation and looking to get at something out of it, you would be expected to be somebody who is able to do the basics of interpretation. So to recognize what rhythms are, recognize STEMI, probably targeted towards people with a few years of experience at looking at ECGs. Otherwise, some of these concepts might seem a little bit confusing. I'd still encourage you to have a look if you're interested, and maybe don't feel that confident. But at the same time, please recognize that this is kind of targeted towards those people. And if this doesn't make sense to you, that's completely okay, because we're hoping to roll out some CPD in the future that might be a little bit more inclusively orientated. So, kind of watch this space. In this presentation, we're going to focus exclusively on occlusive coronary artery etiologies of disease. So more that's like electrophysiological, more rhythm-based stuff, more structural heart disease stuff. We're going to try and cover that in different lectures. So this is exclusively occlusive disease that we'll be focusing on here. Cool. So our objectives are going to be to kind of constructively evaluate the London Ambulance Service heart attack criteria process. We're going to discuss some of the positives and some of the limitations of this process, and we're also going to explore cases of electrocardiographically diagnosable occlusion myocardial infarctions that might not fit into that traditional label of STEMI. And we're going to frame these presentations within kind of the LAS HAC criteria. So that was a lot of big words, and I appreciate that, but I promise it's probably going to make more sense, hopefully, as we go through this presentation. So I think we'll start by kind of reviewing what our LAS HAC STEMI criteria is, which if you're watching this, you should hopefully have a vague idea. I think this has been kind of simplified from the 2009 AHA and ACCF guidelines. But we have kind of males, 2 millimeters of elevation in the anterior lead, or for females, 1.5 millimeters in the anterior lead. That's leads V1 to V4. In England, we kind of combine the septal and the anterior leads to just the anterior leads, which I always thought was confusing when we first moved over here, but that just seems to be the way it's done. And then 1 millimeter or more of elevation in any other leads for both sexes. And remembering we got those posterior and AVR leads where we use half of that. And anyone who falls into this category can be diagnosed as having a STEMI if they've got that chest pain or tightness that's suggestive of ACS. Okay. So left bundle branch block and ventricular paced rhythms. So the current circular that I could find reads that those with left bundle branch blocker or VPR must also look like they're having cardiac chest pain suggestive of ACF and look like they're having an MI. So when I started, patients who had a new left bundle branch blocker in their ECG were presumed to be having an MI and were taken to the cath lab. But on kind of reviewing the current circular, it looks like that's been taken out and replaced with this, which makes a bit of sense to me. I think people would quite commonly get turned away bringing patients with presumed left bundle to cath labs. But I think that whole concept of looking like they're having an MI still rings a little vague, and we're going to get into it a little bit later on with some other ways that we might be able to determine if these patients are infarcting or not. But that's the guideline. And then high-risk ACS. So high-risk ACS hopefully kind of covers everything else. Now, there are some other sections in the circular that kind of talk about atypical presentations of silent MI. And yeah, those unusual presentations, but we're not going to focus on those today. So in the talk, this is when we kind of had a bit of a back and forth about what people's experiences were like with the circular. Feel free to pause the video and have a think about kind of your own experiences with the circular, what you think's good about it, what you think maybe could be improved about it. But what we will do for the sake of this recording edition is we'll just move forward from here, okay? So I'm personally of the opinion that it's a pretty good system, broadly speaking. I think in the LAS, we do have a really broad range of clinicians. And with that, we have a broad range of kind of clinical competencies within the service. And I think the circular does do a good job of providing a basic framework that everyone can work to. It basically kind of like quantifies interpretation down to millimeters of elevation, which is a really simple thing to understand. And I think is overly a good thing when you're kind of looking at the majority of the service. At the same time, I think like the inclusion of that high-risk ACS criteria allows for a bit of autonomy in selecting patients that might be suitable for PCI outside of that traditional STEMI framework. So I think that's a really positive thing as well. I've done some research projects where I've looked at similar guidelines for other ambulance services, predominantly within Australia. And I have to say, by comparison, I think this guideline is quite superior in that it does empower us to be fairly autonomous with some of the decisions that we make about who we bring to a cath lab compared to others, which I think overall is a good thing because it lets us advocate for our patients. So some of the limitations about this tool. I think there are some ways that the tool could potentially be developed a little bit, and the main issue that I see with it is that it's very sort of STEMI orientated. So as we kind of know, and I think what we're going to talk about through this presentation is that ECG interpretation in itself tends to be a little bit more nuanced than just looking at cutoffs of millimeters of ST elevation in our patients. And I think we all know this kind of intuitively. And I'll give an example. We don't really look twice at like the 22-year-old male who's presenting with hyperventilating and tingling in his hands. Even if he's got sort of 3 millimeters of anterior concave elevation, we will be very dismissive of an ECG like that. And this patient will oftentimes end up in the ED or a discharge on scene. Is very, very rarely going to be taken to a heart attack center. But in a patient where they're, elderly with risk factors and maybe they're gray, diaphoretic, sweaty, presenting with that really horrible ACS-like chest pain, we will scrutinize down to the 0.5 millimeter on these ECGs, looking for reasons to take them to the cath lab. And I think a lot of this has to do with that relatively poor sensitivity that STEMI has. So there's a really high rate of false negatives, and we're kind of we're aware of that, and I think we do kind of subconsciously factor that into a lot of our decision making. But fortunately, there are some other systems that we're going to explore in this talk that we can use to critically evaluate our ECGs outside of the STEMI framework. And I hope that this is going to be really useful in becoming a lot more confident in taking the right sort of patients to the cath lab. Okay, hope that's making sense so far. I do appreciate that I tend to talk really quickly, and that this is going to be a lot of theory and a lot of content coming up. So take your time with it. If you need to take some pauses, please do. Okay, so here we do have the traditional pathways that a patient will take if they call the LAS with query ACS. And I do appreciate that it's in reality, it's a little bit more nuanced than this. I'm not sure if you can see my mouse on screen here, but I do really appreciate that kind of under the high-risk ACS pathway, patients can also go to the cath lab directly. They don't necessarily have to meet that STEMI criteria. But for the sake of argument, we're going to say that these are the two traditional pathways that patients can take if they call the LAS and they present with those symptoms of ACS. And the primary decision point that's going to determine disposition for most of these patients is going to be whether their ECG can demonstrate a STEMI or not. Okay. So this group of patients here in the process are the ones that we're going to really focus our case-based analysis today on. So this is the main concept I want to get across. There is a large subsection of patients that we are routinely dismissing as NSTEMIs who are missing timely reperfusion because their diagnosis of myocardial infarction required an A&E admission and troponin testing to determine they were infarcting. Now, within this subsection of patients, there is a percentage of them who presented with those initial ECG findings that were diagnostically equivalent to the patient having presented with a STEMI, okay? So I get that that was pretty wordy and maybe a bit to understand, but we are going to break that down. But that is kind of the crux of everything we want to talk about today, okay? So these are some of the terms that you might be familiar with. They were taught when I was in my undergraduate degree, and they're probably still being taught today. Now, unfortunately, when we kind of dig a bit deeper into MI patients, we recognize that these labels are potentially a bit of an oversimplification and can be a bit misleading. So just because like a patient is diagnosed with an NSTEMI, it doesn't necessarily like indicate that they're having a subtransmural infarct. And just because they have ST elevation, it doesn't indicate that the patient's got a complete occlusion. There are other causes of ST elevation outside of a patient having a complete coronary occlusion. But fortunately, there's a new and more accurate rebranding of MI that we're going to kind of talk about next, okay? So, the NOMI manifesto. So NOMI, or occlusion myocardial infarction, is a concept that was publicized within the online medical education community by the work of Dr. Smith and colleagues. So these guys, Smith, Myers, and Weingart, they're really at the forefront of this movement, and they've put out a few different publications in the area, which we're going to be sort of referring to from out here. So in 2018, they wrote an open access PDF titled the NOMI Manifesto, which kind of breaks down in a lot more detail, kind of like the history of how STEMI and NSTEMI kind of came to be and why it's probably in need of a bit of a paradigm shift. And if you are interested in doing some further reading on this subject when you get to the end of this presentation, I really highly recommend downloading that PDF and having a read through because it's really well written. So OMI, or sometimes it's referred to as ACOMI, ACOMI. It's an acronym that stands for acute coronary occlusion myocardial infarction. And all it means is that the coronary artery has been fully blocked or nearly completely blocked by a thrombus. Now, this kind of rebranding is probably more helpful than using STEMI to describe a myocardial infarct, as ST elevation can be a finding that's independent of infarction, as we've talked about before. Furthermore, NSTEMI does not equate to an unobstructed or an unrecognizable occlusion, which it implies. So one of the big papers that kind of got published in this area and that sparked a lot of this research was called the Difficult Study. It was completed by Aslander and colleagues, and in this study, they enrolled 3,000 patients into STEMI and non-STEMI groups. They were able to reclassify 28.2% of NSTEMI patients as having ECG findings diagnostic of ACO-MI. So to kind of explain that in a little bit more detail, 28.2% of the patients that were dismissed as NSTEMI by kind of applying a different set of rules to their ECG, these cardiologists were able to identify findings that were diagnostically equivalent to whether this patient had presented with STEMI, okay? And furthermore, they discovered that this subgroup of reclassified patients had a higher frequency of myocardial damage, high frequency of in-hospital and long-term mortality compared to the rest of the NSTEMI group. So this is a really high-risk group of patients that we're looking at. So in the references section of this PowerPoint, I'm going to have links to all of these papers, and I'd really encourage people who are interested to do a bit of a deeper dive into, because they're really good reads. But we will move forward. So what I am proposing, and the reason why I've kind of put together this presentation, is that by taking some of the lessons that are being put forward by Dr. Smith and colleagues, we can potentially identify and redirect a significant portion, maybe up to 30% of these patients presenting with NSTEMI to the right destination. And I think that's really important. But why do I think it's important? Well, as has been kind of clearly demonstrated in the literature and repeatedly drilled into our heads since paramedic school or EEC school, time is tissue. So here we can see in a graph taken from a cohort of 5,730 patients, looking at the relationship between ischemic time and mortality. We can see that at the greater than 240-minute delay, mortality rate is approaching double the 120-minute group, the less than 120-minute group. Now, let's have a think about how many minutes of delay the process of conveying a patient to A&E, getting them booked in, having their bloods run, having their case reviewed, having those bloods come back as, positive for infarction, having a second ambulance booked, all the delays associated with us being dispatched, and finally transporting that patient to PCI. I would wager that the probability of this occurring within that 120-minute time frame would be close to, if not 0%. Okay, so that's why I think it's really important to try and get these patients who do need PCI to the right hospital as quickly as possible. But how can we improve? Great question, me. So this is taken from a paper that was published in AHA in 2020, and it's kind of co-authored by a lot of the same people that we talked about, the big players in the NOMI manifesto. And I'm not going to say the name because it's a bit of a mouthful, but the authors kind of completed a retrospective case control study of patients with suspected ACS, and they compared the diagnostic accuracy of STEMI against a blinded cardiologist who used 8 additional findings outside of ST elevation. And I'll quickly go through them now, but it's not so important if you know what I'm talking about, because it's stuff we're going to get into in the case review. But these included hyperacute T waves, including de Winters, reciprocal ST depression, or negative hyperacute T waves, ST depression that was maximal in V1 to V4, pathological Q waves, ST depression and T wave inversion in AVL with suspected inferior myocardial infarct, modified Scarbosa criteria for left bundle branch block and ventricular paced rhythm. And sort of by applying this extended profile, they were able to increase their diagnostic accuracy of MI based on the ECG from 77% to 89%. Which, when you kind of consider like ischemic heart disease is the biggest killer in the country, or in any country in the developed world, that's a huge number of patients that we're potentially talking about. So this makes a real difference, I think. And these are the concepts that we're going to focus on in our case reviews. We're going to basically kind of look beyond STEM. Cool. This is very silly, but you can take the STEMI pill and you can go on counting your millimeters of elevation. Or you can take the ACO-MI pill and you can develop your ECG interpretation skills and you can make better evidence-based decisions for your cardiac patients. I apologize for that. That was very dumb. Okay, case 1. So now we're going to get into our case reviews. That's all of the theory done with, more or less. So thank you for bearing with me up to this point. So the way this works is I'll give you a case. There's going to be very few details on the case because the focus is really on the patient's ECG. And I would encourage you to maybe pause the video a little bit, take some time to kind of have a look at the ECG and come up with your own thoughts about it. And then what I will do is I'll kind of go through my interpretation, and then there'll be some slides afterwards about kind of why I've come to the conclusions I've come to, and we'll be linking each case hopefully to some of those rules that we mentioned previously. Okay. So first case, 35-year-old female patient complaining of non-specific chest pain. Your crewmate looks over at the ECG and he or she assures you that it all looks good before handing it to you. And before we move on to the ECG, I'd just like to point out that like a 35-year-old female, definitely the kind of patient you're not expecting to have an MI. Very young to be having an MI, and also female, which, you know, have lower chances of infarcting than men. So this is the kind of patient whose ECG, I mean, I'm completely guilty of doing this, would be quite tempted to have just a glance over and probably not scrutinize in as much detail as is warranted. So I guess just by, you know, throwing in a patient with this age group and this gender kind of makes you think about some of the biases that we might have kind of going into looking at ECGs, and to be aware of them, because all ages of patients can have infarcts and all genders of patients can have infarcts. And there's definitely been people younger than 35 who have had infarcts. So, you know, just bear it in mind. Okay, so here is our ECG. Now, this is the time where, if you want, I would encourage you to pause the video, have a look, and kind of try and come up with a working diagnosis yourself. And kind of answer the question on if you would take this patient to a cath lab on. So I'm going to give you a few seconds to do that. And now I'm going to kind of go through my interpretation. So when I'm looking at an ECG, I like to kind of look at the overall ECG first. There's a really great cardiologist on YouTube, an electrophysiologist actually, called the ECG Doc, and he talks about looking at the forest before you look at the trees. And I think that's a really, like, that's a cool point, and that's something that I tend to do. And I think what he means by that is the forest is like the overall ECG, just having a bit of a general vibe, if you will, before kind of going down and looking at the nitty gritty. And I think when I look at the forest of this ECG personally, I'm actually not that alarmed. It looks sinus, like it's regular. There's a P wave before every QRS. All of the, you know, the axis is normal. There's normal looking R wave progression. I would say generally this ECG looks pretty fine. But after kind of looking at the forest is when we sort of look at the trees individually. And I guess the way I like to do it is I just start at lead 1 and look at my high lateral leads, which is lead 1 and AVL. Look at my inferior leads, look at my septal or anterior, which is V1, V2, then look at my anterior, which is V3, V4. Sorry if I get that confused. Again, we kind of refer to V1, V2 as septal leads and V3, V4 as anterior leads, where I trained. But in the UK, V1 to V4 is anterior. So I'll try and use that UK nomenclature from here on out. But if I do misspeak, I do apologize. And then we have our low lateral leads, V5, V6. So that's the order that I like to do it, but I don't think there's any wrong or right way to do this. And then don't ever forget about AVR for reasons we'll come to later. But yeah, so looking at my lateral leads, I look at V1, it looks pretty normal. There's potentially a tiny bit of ST depression here, but with the shoddy quality of this JPEG, I'm not able to determine exactly how much. I would say it's not super clinically, actually, it's probably about 0.5 mil. You can see it a bit clearer on that third beat. Okay, and then we're going to come down here to AVL. So these are our high lateral leads. And in AVL, I have some sinus beats, and I do have a T-wave inversion, which is unusual for AVL. And I've also got ST depression, about 1 millimeter, maybe just under 1 millimeter of ST depression in AVL. that should be ringing alarm bells. That's not normal. That's actually quite concerning, okay, for reasons we're going to get into in the next slide. But now we'll look at our inferior leads. We have our P waves, which look okay. Sorry, I was just trying to calculate if there's a first degree AV block, which remember is less than 200, greater than 200 milliseconds, which would be 5 small squares or 1 big square. And I think this patient's kind of borderline, but not significant enough to the point that I'd say that this is a first degree AVB. But anyway, that's irrelevant because looking at our ST segment, there's a little bit of elevation here, very, very kind of minor amount, I would say 0.5 millimeter, nothing to really write home about. Lead 3, so our inferior leads that we remember 2, 3, and AVF. We have a bit of a Q wave in lead 3 developing. This can be a normal variant, so on its own, I wouldn't say I'm too concerned about that. But we do have about 1 millimeter of ST elevation here. And that is concerning. That's not normal. So if this is our isoelectric line here, I'm not sure if you can see my mouse. I hope you can. Then we would have about 1 millimeter, or potentially even just under 1 millimeter of elevation. In fact, I think I can annotate this. And hopefully you guys are going to be able to see it if I can keep my hand straight, which I cannot. But you can see this is probably our isoelectric line here, where at the top of where that blue line ends. And we have about 1 millimeter of ST elevation. So that is alarming. And then in AVF, again, we look at our isoelectric line. And we measure, so we're just going to use the PR segment to kind of determine our isoelectric line. And if we draw a straight line, we do see that we have about just under 1 millimeter of ST elevation in AVF. So we know that our STEMI criteria requires us to have greater than 1 millimeter of ST elevation in 2 contiguous leads. I would say this is pretty borderline. I think this maybe just falls shy of having 1 millimeter of elevation here, although it's admittedly really hard to tell with these shoddy JPEGs that I'm using. But already we're probably quite concerned about this patient having an inferior infarct, I would say. Then we kind of look at the rest of our leads. Our wave progression looks fairly normal. There's nothing really standoutish about any of these T waves or ST segments in the rest of the leads. Okay, so it's definitely our inferior leads and our lateral leads that are a bit unknown. But yeah, I hope you can see my drawings. I'm pretty sure that you'll be able to. Otherwise, this is going to be very embarrassing when I get to the end of this recording. But we'll clear them and we'll move along. So these changes were not, jumping ahead of myself a little bit. These changes were not picked up on the patient's ECG. I think this was taken from an ED case. I did actually change the age and the gender of the patient just to be a little bit misleading, and just so that we could have a conversation about bias when it comes to ECG patients. I think in this case, it was an older male patient. I can't remember off the top of my head, but this was a real case. And this ECG was not picked up in ED, and it was labeled as normal sinus rhythm. And then troponin returned extremely elevated, 1500 nanograms per milliliter, and I don't think we talked about our cutoff earlier, but you could have seen it in one of the slides. Normal cutoff, that's diagnostic event STEMI, is 14 nanograms per liter. And angiography demonstrated 80% occlusion of the RCA. So right coronary artery, remember we have our heart. That's probably a bad color to use here. We have our heart. Oh my God, that is a bad drawing of our heart. But the RCA comes down and it supplies sort of right ventricle with blood, and the right ventricle is best sort of observed in the ECG by our inferior leads, and sort of V1, V2 kind of looks at the top of it as well. Okay, so this finding here kind of supports that concern that we had for inferior infarction in our patient. Okay, but how could we know? I guess how could we know that this patient was having an inferior? So the key is AVL, actually. Reciprocal ST depression in AVL is more sensitive than STEMI criteria for identifying inferior infarction. That's pretty mind-blowing. So it can also reliably differentiate pericarditis, which is like a common STEMI mimic, from inferior STEMI. So let me just, cool. Yeah, so AVL is the key, basically. If you're suspecting someone might be having an inferior infarct, if I've got those borderline looking ST segments in the inferior leads, have a look at AVL. Is it depressed? Is there an inverted T wave? If so, be really concerned, okay? And remember, this is for those patients who are presenting with ACS type chest pain, okay? So here's our rule. It's taken from the NOMI manifesto. And it states that any amount of STD in AVL, any STE in the inferior leads is MI until proven otherwise. And it's got a sensitivity of 99%, a specificity of 100%. Now, I did have a look at some of the research that this comes from. I may have included it in my notes. Bear with. It's not in my show notes, but I do have it in my Obsidian notes. Okay, cool. So the evidence comes from a paper that was written by Bishkov et al. In 2016. Sorry about the delay there, very unprofessional. And in their paper, they did a retrospective cohort study, and they looked at 154 inferior STEMI patients, and they found that all of their inferior STEMI patients had some amount of ST depression in AVL. They also looked at 49 patients who had pericarditis. And in these patients, they all had inferior ST elevation, but none of them had any ST segment depression in lead AVL. So that's where that can reliably differentiate pericarditis comes in. Now, of 54 patients who had subtle inferior MIs, and I think they defined subtle, I don't have it written down here, but from my head, they defined subtle as having less than 1 millimeter of inferior ST elevation. They found, so of 54 subtle MIs, they found that 49 of them had ST depression in AVL. So sensitivity gets a little bit poorer when we're talking about this subtle influx. However, a really big strength of this study is that all of these MIs were confirmed angiographically. So although this isn't the hugest sample size, it's really, really promising. And I think something that I will try and do throughout this presentation is really refer to the literature that kind of informs a lot of these guidelines. And because a lot of this is really coming out of the last kind of 5 to 10 years, you will find that it tends to be retrospective cohort studies, and the cohorts tend not to be massive. So one thing I want to emphasize early is that although these rules can report really outstanding sensitivities and specificities and seem really, really good, we do need longitudinal research projects to kind of continue to support these ideas, okay? So if any of you are interested in doing careers in research and like cardiology, there's probably a lot of space here to start some research projects. Just for anyone doing their masters or dissertations or anything like that, just keep that in mind, because I would be really interested in reading those projects. But moving on, case 2, 45-year-old smoker, history chest pain. Bam. I think these are the actual details of the patient in this instance. So here's his ECG. Have a pause here, have a bit of a think about the ECG. Feel free to apply that method of interpretation that I talked about before. But yeah, away you go. Cool, so welcome back. Hopefully you paused it, otherwise it's kind of just me awkwardly sort of pausing and monologuing. But yeah, let's interpret. So forests and trees. Looking at the forest of this one, it's a little strange. There's a few things going on that aren't super typical of a normal ECG, I would say. Definitely kind of have my guard up a little bit going into this one. And I think, that looking at the forest thing, it is just like, it's a gestalt thing, like if you see 1,000 normal ECGs, which if you have some experience in doing this sort of thing, most of you probably have seen thousands upon thousands of ECGs at this point in your career. you do just sort of get the vibe, I guess, of the ECG sometimes. You just like look at it, you're like, yeah, the vibe's off. That's kind of how I feel about this one, and I'm sure it's how a lot of you guys feel. But yeah, and I think it's absolutely okay to kind of like start your analysis with that sort of approach, as long as as long as you kind of go a little bit deeper and don't just hand your ECG back and go, yeah, the vibe's off. I hope that makes sense. But anyway, so now we are going to look a little bit deeper. Let's start with our lateral leads. So, okay, first thing I notice is like the PR interval appears kind of short, like, you know, this space here between our P wave and our R wave. Realistically, this should be like between, sorry, mentally blanking a little bit, between 120 and 200 milliseconds. And this appears a little bit short to me. Again, I can't fully see because like I'm looking pretty close here. I think it's about two squares maybe. That's 80 milliseconds. So we want it to be, you know, at least more than 120 milliseconds. So PR interval short. So we can put that down short PR. Sorry about my writing. I'm writing with a mouse on a desk with no mouse pad. So and yeah, and then I kind of like, because I'm interested in this like PR segment, I mean, we can go through and look at AVL, but I'm going to look at lead 2 because that's the best lead usually to view our P waves in. And yeah, I definitely confirm that like our PR segment is short, and also the morphology of the P wave is a little bit unusual. It's kind of like got this almost wriggly bifid thing to it. Like a properly bifid P wave like this would suggest like P mitrale, but like usually with P mitrale, which is like, you know, suggestive of left atrial enlargement. If you don't know what it is, just do a quick Google. It'll probably explain it much better than I can, but it's basically just a P wave abnormality where the P wave kind of looks like an M shape, and it's usually quite large, and it suggests that the left atria is big. But I wouldn't say this looks like P mitrale just because of the size of the P wave. So what I would suggest, and then if I look at like the P waves in the other leads, like it's like, oh my God, where are they? They're like missing. That's weird. So yeah, I don't, you know, I can only really speculate as to why this is happening, but like, I would say it would suggest to me that like potentially this P wave is coming from somewhere that's not the SA node. It's not like the normal part where P waves do come from, and that might indicate some like disease of the SA node. Like if it's this P wave is kind of originating like extratopically, which I think could be the case here. And you know, the fact that there's disease of the SA node, like we know the SA node is perfused by the RCA, the right coronary artery, so that might give us a bit of a clue as to what could be going on here. But this is all very speculative for me. I mean, like, you might have a better idea as to what's going on here, and if you do, I'd love to hear it, because like I said, this is ideally a bit of a back and forth. But yeah, so anyway, looking at the rest of our lateral leads, we have a bit of a weird looking, I know weird's not like a clinical term, but we do have this like weird upsloping ST segment, which is kind of non-specific in isolation, but like it's not normal. And then we look at AVL. We have like an RSR pattern, which again is pretty non-specific, but like we do have an inverted T wave. And if I could draw straight, which I can't, you would see that we also have ST depression and T wave inversion. So immediately, we should be suspicious for inferior myocardial infarction in this patient. So we're going to look at our inferior leads, 2, 3, AVF, and we're going to come across. And sure enough, well, I really cannot draw straight. I'm sorry, guys. Yeah, but sure enough, we do have some ST changes. We have some clear ST elevation, probably a bit over a millimeter in both 3 and AVF. So this is actually a patient who's meeting STEMI criteria. I think our last one probably wasn't quite meeting STEMI criteria, but this one definitely is. And we've looked at AVL, so we confirmed that that's concerning. We got some other changes in the ECG as well, like we got ST depression, kind of these strange upsloping T waves in V2. Again, we have that same sort of like unusual morphology V4, all relatively non-specific. But I think what could catch some people out with this ECG is that we do have quite consistent like J point notching here. I don't know if you guys can see that. over all of my drawing because I made an absolute mess of this ECG. But J-point notching is one of those, whoa, that's bad. I'm sorry, but J-point notching is one of those things that generally we kind of associate with benign early repolarization. And I think with this ECG, there could be a temptation to see that notching, see that ST elevation, and be quite dismissive of it as BER. But remember that if we kind of look at AVL and we see that T-wave inversion and we see that ST depression, then I mean, like, this is not BER. This is a patient having an inferior occlusion. Probably in the quite early phases of doing so. We can also see that there's some Q waves developing here, but they're not massive Q waves. So this is probably likely to be a more acute infarction. We see that like patients who have had longer infarctions tend to develop more prominent Q waves. So that's sort of what I mean by that. But yeah, okay, cool. So we should be concerned about this patient. But this was another ED case. They weren't concerned about this patient. He was discharged because his CHOPS came back as negative. He represented the next day and his CHOPS were 20,000. I assume that's nanograms per liter, but I'm not per milliliter, but I'm not entirely sure. Angiography demonstrated total occlusion of his right coronary artery. So yeah, not good. And when you think about how, delays to reperfusion associated with greater mortality, fortunately, that wasn't the case in this guy. But like, if you think of the damage to his myocardium and how irreversible a lot of that is now, what kind of like outcomes he might have in terms of this affecting his ejection fraction or heart failure or, all of those other things. It's important that we get these patients to the right places early and we're not dismissive of their symptoms. I don't fully understand why his troponin would have been negative in the first instance. I might have to do a bit more reading on that. If anyone knows the answer, please send me an email. Potentially his artery wasn't completely occluded at the point that he was in the ED, and maybe some blood was still flowing through. But yeah, not too sure. Okay, so case 3. Moving on, we got a 50-year-old male. He's got chest pain and dyspnea. Whoa, spoilers. I hope no one saw that. But if you did, I'm sorry. Anyway, here's your time to pause the video. Have a look. Tell me what you think. Actually, yeah, cool. All right, so I'm not going to painstakingly break down every single ECG kind of going forward from here. I think I've given you 2 where I've kind of explained my process a little bit. So from this point out, I'm kind of just going to focus mainly on the abnormal and not really bring attention to the normal, if that makes sense. So again, kind of looking at the forest of his ECG, there's a lot of things that stand out to me as being concerning. It doesn't look normal in a few different ways. So we're going to kind of like break it down with a pretty high degree of scrutiny. Looking at our high lateral leads, we do have PQRST. We do have what looks like a little bit of PR segment depression. Now, this is something that's really hard to notice if you're not looking for it. But if this is our isoelectric line here, and if I can draw a straight line, which I can't, I really need to get one of those like touchpad things. So here's our, oh my God, here's our isoelectric line here. Oh my Lord. One more try and then I'm going to give up. All right, you can't really see it because I haven't done a really good job, but there is a tiny bit of PR segment depression in these leads. And what's meant by that is like, this is our P wave, here is our R wave. Like here's the P wave and here's the R wave. And then between these sections, we have the PR depression, the PR segment, which is here. We talked a bit about the PR segment before, saying that it needs to be between 120 and 200 milliseconds. But something else that the PR segment needs to be is it needs to be isoelectric. So it needs to be the same, it needs to be kind of the same amplitude as this segment here. And here we can see that it's actually slightly depressed. So moving on, AVL looks fine. We have a P wave QRST. The ST segment looks good. The T wave is not inverted. And then we look at our inferior leads. Again, we can see a little bit of PR segment depression. You can see it there. I mean, again, my lines are crap, but it's very minimal. Like it's very borderline, to be honest, but it definitely is there. We see ST elevation as well in our inferior leads. We see a pretty funky kind of looking downward sloping ST segment here. That's kind of unusual. We got another bit of ST elevation in AVF. Looking for our anterior leads, we have good R wave progression. That looks normal. V1, V2 looks normal. V3, we have some ST elevation here. V4, we have a tiny bit of ST elevation as well. V5 is a little bit elevated, and V6 is a little bit elevated. So a lot of like what I'd describe as like pretty minimal ST elevation, but globally and probably meeting criteria. I'm not going to count it, but I imagine in these inferior leads, we're going to be more than a mil of elevation. So I think this patient's probably meeting STEMI criteria. Moving on. So putting all of this together, the patient very likely has pericarditis. And we can kind of tell this because of that global pattern of ST elevation. It's in the anterior, it's in the inferior, it's in the lateral, it's everywhere. Which is pretty unusual when you think if someone's having an MI, it's an occlusion of a specific coronary artery that perfuses a specific part of our heart. So if they're infarcting, you're going to kind of expect that elevation to generally just be in the area of that heart that's kind of occluded. So it is kind of unusual to see global ST elevation in someone who's having a coronary occlusion, although it's not impossible. PR segment depression is another finding that's really commonly associated with pericarditis. So for those of you who don't know what pericarditis is, I appreciate I've kind of just assumed that we know what we're talking about here. So this is our heart. Oh my God. Oh, fuck. My drawings are so bad. Sorry. I'm really sorry about the quality of these drawings. I'm using a mouse. I mean, I might as well be in paint. But anyway, here's our heart. And let's just say that, like, oh Lord have mercy. Oh God. Oh Lord. All right. So yeah, that monstrosity is your heart, allegedly. And it has 3 layers to it, basically. We have like the endocardium, which is like the innermost layer of the heart. We have the myocardium, which is like the heart muscle. And now the whole heart sits in something called the pericardium. So the pericardium is like, I don't know, it's like a little sac, and the heart sits in it. And I don't actually fully get what its job is. I should probably look that up and explain it. But it's probably protective or something. But it contains the heart. It's like a sac that the heart sits in, and the heart beats inside of a little sac. If you've ever seen that, like, you know, when hems crack open someone's chest during a thoracotomy, you often see them cut through the pericardium so that they can get a good look at the heart. Because, you know, cardiac tamponade, blood filling up in that pericardium is one of those causes of traumatic cardiac arrest. But I am really digressing here. One of the other things that the pericardium can do that's not so good is it can get inflamed, usually because of viral infection. And when it does, it can cause chest pain. The chest pain associated with pericarditis, it's usually worse when the patient leans forward. It's usually worse when the patient takes a deep breath in. It can be, and is often associated with a slight temperature. And it can be associated with ECG changes as well, depending on the stage of progression of disease. So, and those ECG changes are kind of what we're talking about here, and it's what's going on with this patient. Now, the question is, do you take this patient to a cath lab or not? And my answer would be, and it might be a little bit controversial, and I definitely appreciate that this is a nuanced topic of discussion, but I would say if you're faced with a patient who's 50 years old and they have chest pain and shortness of breath, and they are presenting with an ECG that meets STEMI criteria, even if you think this is pericarditis, I believe you should be taking this patient to a cath lab. Let them make that decision. Let them stand the patient down. On the balance of risk, this is an older male. This is a patient who's a smoker. There's some risk factors here. You don't want to get this wrong. So although you can bring it to them and say, hey, I'm sorry, I think this patient has pericarditis, but they're meeting our STEMI criteria, and hence why I've come here. They're not going to be, hopefully, but they shouldn't be rude to you. They shouldn't be dismissive of you. They can come down as they do and do a few extra assessments, maybe do an echo, look at the patient's pericardium, see if there's any fluid there, do some auscultation to see if they can hear that pericardial friction murmur. And then they can make that diagnosis for you, okay? So particularly in this patient who's higher risk and a little bit older, I would be really, really hesitant to just be like, hey, this is pericarditis, we're going to A&E, okay? Now, if this is like a 21-year-old with like a history of repeated pericarditis and he's like, yeah, this feels exactly the same as it always does, chief. And you do those things and you listen for the friction rub and he leans forward and he's like, yeah, that's much worse, chief. And the ECG's screaming pericarditis. I mean, look, patient care is nuanced. It's case by case. I don't think there's any absolute rule for anything, okay? So just bear it in mind, but that's kind of what we're getting at here. I hope that makes sense. If it doesn't, send me an email. It's kind of awkward doing this whole pre-recorded thing because I can't have that back and forth. And I think cases like that where it is a little bit of a gray area, that are the ones that's really nice to have them back and forth in. But anyway, moving on. 66-year-old male, onset of central chest pain, and it's been less than 30 minutes. So by some fucking miracle, we've gotten to this ambulance really fast. No calls holding. He's called up immediately, and you're at his doorstep in 30 minutes. That's great. And here's his ECG. And I'm going to force you to have a look at this one because I'm going to go get some water. So you don't need to pause the video. Maybe I'll be back. Okay. I'm going to start talking about it. So if you're still interpreting, pause here. And I'll see you when you're finished. But for those of you who are fast, let's get going. So again, looking at the forest, this ECG looks off to me. There's a few things that really stand out, like those massive T waves in our precordial leads, the fact that everything's pointing in weird directions in our inferior leads. And yeah, definitely going to kind of want to have a really close look at the trees. So starting with our high lateral leads, that is. I don't know if anyone else does this, but I refer to the high lateral leads as one AVL and the low lateral leads as G5, V6, whereas I know some people just refer to all of them as the lateral leads. The reason I do that is because one and AVL are reciprocal. They're opposite of the inferior leads. In fact, AVL is completely opposite of the inferior leads. So I think it helps me in my head sort of remember that high lateral is going to be where the reciprocal changes from inferior are. But a bit of a side. Anyway, moving on. So yeah, lateral leads, little. I mean, it looks pretty normal to be honest. AVL, yeah, okay, this is where it looks a bit strange. I mean, yeah, something kind of like doesn't look right here, but I can't quite put my finger on it. It might be just sort of like the shape and the amplitude of the T wave. And then when I look at AVL, yeah, the amplitude of the T wave is actually kind of concerning here. And you might be like, well, actually, that T wave isn't that big. But when you kind of compare it with the size of the preceding QRS complex, that's when you might think, oh, okay, actually, yeah, relative to the amplitude of that preceding complex, the T wave is quite large. And that should be like a little bit alarming. And we have a small Q wave here, which is fine. Inverted P wave in 2, no idea why that is. It might be that there's some structural changes to this patient's heart. It could also indicate that we have a different foci of our atrial beat. It's not coming from the SA node. I honestly have no idea. If anyone's got any strong ideas, let me know. But yeah, we've got another inverted P wave in lead 3. That's unusual. We've got a bit of an unusual kind of looking S wave. It's very narrow. And then we got T wave inversion and what looks like a little bit of ST depression in lead 3. Same sort of pattern. Yeah, same sort of pattern going on in AVF with kind of like an isoelectric T wave. That's unusual. A lot of like pretty unusual but non-specific changes, I'd say, happening so far. But then we get to our like precordial leads, and that's when we see like some massive T waves. They really stand out. We also have like a loss of R wave kind of progression. In fact, we just have these deep Q waves. I'm drawing all over this and making a mess of it, but we do have these deep Q waves in V2 and V3. So all of this is pretty alarming. And then again, we got like some pretty significant ST depression in V4, V5, V6. So yeah, this should all be kind of triggering alarm bells for people. Hopefully, we can take this patient to a heart attack center based on the fact that they've got these depressed ST segments under our high-risk ACS criteria, and that would absolutely be the right thing to do with this patient because they're going to need angiography because these are De Winter's T waves. So that defined as tall, prominent, symmetrical T waves in the precordial leads. That's the chest leads, so leads V1 to 6. They're usually associated with this kind of like upsloping ST depression that we kind of like picked up on here. And yeah, so they're pretty rare. There's a less than about 2% incidence in anterior MI. But the thing to take away is that this pattern is often under-recognized by clinicians. And it signifies that this patient's having a complete left anterior descending occlusion. So basically, like the reason behind why these T waves occur, we kind of alluded to it a little bit before, but like the ECG changes depending on like how long the patient has been infarcting for. And in that really hyperacute phase of infarction, like the really early presenters, the first thing that changes is the T waves just become tall. The ST segment generally stays about the same, but the T waves become massive. They become peaked. We refer to it usually as HATW or hyperacute T waves. And anyway, so with these T wave changes over time, the T waves come down in size and the ST segment elevates. And then over time, the T wave may invert, the Q waves will start to become a lot bigger. And then you get kind of like left with this kind of persistent pattern where the patient will generally kind of have these persistent Q waves, but normalization of the ST-T wave segment. And that's how, you know, when like you're on your LAS HAC 15 and it says, old inferior myocardial infarction in the printout, it's usually because it's detecting some Q waves there. That's how that's kind of done. And sometimes it's right, sometimes it's completely wrong. But yeah, De Winter's. This is a good one to know about. I have never seen this on the road. It's relatively rare, but this is good to know about. So case 5, 56-year-old male patient, multiple comorbidities, flank pain. And that's our ECG. So take a second to pause. Also, like, there's a lot of content in this presentation. I mean, we're up to case 5. I don't remember how many of these I wrote, but I think there's more than 10. There's a few. So, like, if you want to, like, stop this video, come back to it later, don't feel like you have to march through all of this all at once. I felt a bit sorry for some of the people in the on the presentation day because this is a lot of content to cover, and I can appreciate that it's going to get exhausting. So yeah, please absolutely come back to this in chunks. Don't feel pressure to watch it the whole way through. But yeah, anyway, I'm going to interpret this ECG. So looking at the forest, this forest is fucked. I've never seen an ECG like this before, and it looks wild. I don't even know what is what, if I'm being honest. And I'm sure a lot of you feel the same way. I mean, like, what is even going on here? Oh, whoa, spoilers. I gotta stop doing that. But these, I mean, like, what? Where do I begin? Where is the QR? Where's the P wave? Is this the P wave? I don't know. Is this the QRS complex? Is this the T wave? I guess, maybe. Could that be the P wave? I mean, it's really hard to tell. What's the axis? Where's the isoelectric line? I guess it's this. So is the QRS complex going down? Is it a discordant T wave? Does that mean it's a right axis? I mean, honestly, I'm just speculating. I have got no idea. It looks bizarre, okay? It looks very bizarre. I can try and go through this, but like, okay, I think this might be a P wave, and I think this might be a QRS. But then what is this? Honestly, I can't make tails or ends of this ECG. But what I can tell you is it's regular. It's a little bit quick, it looks like. We can kind of figure out how quick by kind of like choosing this point. You can go 300, 150, 100, 75. So it's probably about 90. So it's not actually terribly quick. If anyone's curious about what I just did there, like there's a technique in ECG interpretation where, like, you know how obviously our x-axis is time, right? Like this is time. And the space between, like, you know, here and here is a certain amount of like time, right? Well, if we kind of like pick a QRS complex that like roughly lines up on like one of these bigger waves here, one of these bigger lines, and we kind of count across the first line, if there's another QRS complex, the rate of that ECG is going to be 300 beats a minute. If we come across again, and it's like on the second line, the rate's going to be 150. So I'll write this in. So, and you can remember that because it's half of 300. And then if we come across again, it's going to be 100 beats a minute. Okay, and we can remember that because it's a third of it's a third of it's a third of 300. Yeah, 100 beats a minute. Sorry, brain fog. And then if we come across again, it's going to be 75, and that's like I don't know. You just have to remember these numbers. There's probably ways to do it, but I just kind of remember them. Okay, and most of your ECGs, and then if we come across again, it's 60. So you kind of just have to remember those numbers. But if you don't, you can kind of just Google it on your phone, ECG rate, Google images, and it'll come up. And you do that like 10 times, and then you'll have committed to memory. And there's probably like a clever way to remember it, but I'm not clever. But yeah, anyway, so you can use that as like a way to approximate your rates of ECGs. And it's like a guesstimate thing. Like it's not fully accurate when they don't like fall exactly on the line, but like, you know, not like everyone's just kind of reading it for monitor when it comes to rate anyway, and that's fine. Just I wouldn't bother. I think it would be like wasted brain space trying to remember any of the other various formulas that you can use to figure out rate. But anyway, point with this ECG, it's looking bizarre. We do have like some massive hyperacute T waves. We've got some really massive QRS complexes as well. It's very hard to see where the P waves are. I think they fall in there somewhere because I can see a bunch of notching, and notching generally indicates that there's a P wave superimposed on something, but I can't tell if it's on this or on this. And we do have that kind of similar, like upward sloping ST depression kind of in V5, V6. So it looks a little bit like De Winter's possibly, but there's just so much else going on with this ECG. And if any of you have sharp eyes, and when I messed up earlier, kind of caught a glimpse of the next slide, you'd see that this patient has a serum potassium of 9.3. So normal potassium should be between 3.5 and 5. 9.3 is extremely elevated. This is a condition known as hyperkalemia. And we can see it in patients who have things like, you know, dialysis patients who have missed their appointments, or people with end-stage renal failure. Some kinds of carcinomas, like cancers, can secrete potassium. There are a range of different conditions that can cause hyperkalemia. And when you see an ECG that just has really bizarre morphology, broad QRS complexes, long QT intervals, long PR intervals, tiny P waves or diminished P waves, and really tall T waves, think long QT. Yeah, I'm gonna do something kind of. I've got a copy of like a. Oh my god! I just said think long QT. I'm sorry. Think hyperkalemia. Long QT is something completely different. I got a copy of like an ECG. I'm just gonna go get from a patient. This is from like a clinical journal of mine, but I don't know if you can see here. But this is a Ross ECG for like learning points. And you know, the readout was telling me he was having a STEMI. I thought it was possible he was having a STEMI, but he had these really like kind of bizarre, like looking, you know, QRS complexes in these really, really tall T waves. I didn't see any T waves either, which, you know, but yeah, I ended up like taking him to the local hospital thinking that this was a hyperkalemic ECG. And I didn't get any pushback from that. They did ask me had I consulted cardiology to make that decision. I said, look, no, it was just more consistent with his history. His history was a gradual decline. He was a cancer patient. It wasn't antipalliative or anything like that. And they were very supportive of me bringing this patient to them, sort of based on that history and based on those ECG findings. So it wasn't challenged. And he did end up having high serum potassium. He died regardless of all of that. But yeah, it's just to say that, you know, if your patient history supports it and you see these really bizarre looking T waves, feel that you can be empowered to kind of, you know, go to your local hospital with this patient. But on the other hand, if your patient is looking like an ACS patient and they're clutching their chest and they're grey, they're diaphoretic, etc., don't be going, hey, this is hyperkalemia, I'm going to take you to the King George Hospital. Please take them to Barts, okay? So, case 70, early 70s female, atypical chest pain, previous history of stent. Here is the ECG. Have a pause. But I'm just going to launch right into it. So, yeah, cool. So forest trees, forest actually looks okay to me on this one. I do notice that there are some Q waves through the anterior, but she has a previous history of a stent, so that's probably an old infarction. Not so troubling. I also noticed that there are some kind of like kind of bizarre looking inferior stuff, but like nothing kind of screaming out as she's having a STEMI. So anyway, we're gonna then look at the trees a little bit. So what do we notice? One, ABF. Okay, we got a deeply inverted T wave in ABF, and we do have an inverted T wave in lead one as well. The actual ST segment looks fine. It's downward sloping, but it's roughly isoelectric. So that's okay. Now, what else have we got going on here? I think that's the first degree heart block. I'm just looking at lead 2. So remember, lead 2 is the best lead to look at your PR intervals. And if I kind of count this out, it's bigger than one of these squares here. So she is having a first degree AV block, which again is not super specific. She's older, isn't she? Like, you know, people get first degree heart blocks. She's got previous cardiac history, so perhaps her conduction system's not what it used to be or whatever. It's pretty non-specific as a finding, but anyway, we're going to keep it in the back of our minds. And we're going to also remember that like diseases of the SA node tend to be from the RCA occlusions or RCA ischemia, shall we say. But anyway, and then I look at lead 2 a little bit more, and I look at kind of like the you know, the axis is normal, the QRS is in both directions, 1 and 2, so that's cool. But then I look at this T wave. This T wave has me a little stumped because it's the same height as the QRS complex. That's a little weird. That's not normal. So then I look at lead 3 over here, and I look at the amplitude of the T wave, and it's probably about the same as the amplitude of a preceding QRS complex. That has me a little stumped. That's not normal. And then I look at AVF and I see this tiny little QRS complex, and I see this proportionately massive T wave. Now I'm concerned. And when I couple that with this inverted T wave in AVL, now I'm really concerned. So you might be thinking to yourself, well, Louis, those T waves aren't that big, really. I mean, if I was to do my own ECG, my T waves would probably be bigger than that in your inferior leads. And you would be absolutely right to say so. But the issue with this patient is that her QRS complex in AVF is tiny. T waves and ST segments in general should be like viewed in proportion to the size of the preceding QRS complex. Okay. Now there are some ratios that'll be thrown around on the internet that have kind of been proposed in order to kind of like quantify this a little bit. But one of the difficulty with this type of patients is that there's no expert consensus on what a hyperacute T wave should be defined as. Okay. Which makes it really difficult to diagnose sort of MI in this sense. But there are some cardiologists out there who would consider this ECG to be diagnostically equivalent of a patient having a STEMI. I wouldn't be so brash personally. I think this is really concerning. I think this is suggestive. I'd probably want to see a few more changes before I am committed to the diagnosis of STEMI in this patient, but I can totally understand where they're coming from. And yeah, does that concept make sense to people? I hope so. I can't hear you say yes, but I hope so. If not, chuck me an email. We can go through some more cases about this sort of thing. Okay, and then I look at the rest of ECG because I'm not getting too tunnel focused. AVR is fine. We do have, like I said, so normally we would see like an R wave and a QRS complex in V3. We don't have that. We just have a Q wave. This is because this patient has had a previous anterior MI. Remember, like we talked about with the progression of how like STEMI progresses, this is probably what's happened here. We got T wave inversion, and we've got some shit going on here too. Okay. This is probably all non-specific. I would say I'd say these changes are likely from that old MI, and these ones here are, God, I hate how I'm doing this. I can only imagine how this looks. I'd say these changes here are probably acute. Okay. This is just my speculation. I could be wrong about this. Like, you know, if I'm talking gibberish and you're more well-informed than me, or you have any different ideas to me, like, I'm really open to hear them. Like, I want to learn just as much as you do being here. So please absolutely hit me up. This is just what I have kind of garnered from the research that I've done on ECGs and my experience in the field. But like, you know, I'm human. I make mistakes. So please let me know. And like I said, a lot of these cases, I picked them because they're very nuanced. And I don't necessarily think there's right or wrong answers about some of these. But anyway, Akemi and not Akemi, that was cute of me to write. But basically, this is like, you know, if you blew up the size of the QRS complex, this T wave would look massive, is the point I was trying to get across with this slide. Okay. So would you take this patient to a cath lab? I would, I believe. Actually, I think I can take them. So it's kind of funny. I can take them because of these T wave inversions, I can take them under high risk ACS. Although that's like not the actual aspect of ECG I'm worried about. But I could take them under high risk ACS. And that's the cool thing about high risk ACS, man, is that like you can include a lot of patients who don't have STEMI, who you are concerned about under that pathway. I would, but if I wasn't going to, what I would do is remember what we talked about earlier, how like hyperacute T waves are one of those really, really early signs of infarction. I would be repeating the ECG on this patient every 10 minutes. And I'd be looking for those dynamic changes for the T waves to be further increasing in amplitude and for that ST segment to be increasing as well. Something I don't think we do enough of in the LAS is repeat ECGs. I think it's usually a one and done deal. Any patient that you're concerned is having ACS, and what I mean by ACS is like you think they have cardiac chest pain that's caused by their heart, Like, don't get me wrong, if you think this is skeletal, if you think this is good, like one and dump all day, every day. But like for these patients, I really think it's important that we repeat the ECG every 10 minutes, every 15 minutes. I have seen in my experience, I've put ECGs on patients, it has been normal. I have seen them develop an MI in front of my eyes where they've gotten the hyperacute T waves, they've gotten the ST segment. And I have also seen a crewmate, literally, it's crazy, one of the craziest cardiology things I've ever seen. He talked a patient out of having an MI. I swear to God, he like spoke to him in such a calm and such a reassuring manner that it like chilled him out. He got less stressed. His myocardial workload decreased, and his 99% stenosed RCA suddenly could meet the oxygen demand of his myocardium that wasn't working so hard because he didn't have quite as much adrenaline and noradrenaline circulating because like my crewmate was chilling this guy out so much. And I swear to God, he talked the patient out of having an MI. I mean, he still had an MI, like, you know, you still need to go to cath lab and get that shit stented. But like, I know, man, it just goes to show like how important patient demeanor is and like also how important it is to repeat ECGs. Because if we'd want to dump this guy, we would have taken him to the local query fucking anxiety or something. I don't know. But like, yeah, I hope that's helpful to you. I know I'm doing a lot of rambling in this. This is my first time with this sort of form of content. So there's going to be a survey at the end. If I talk too much, let me know if this is not useful. But I hope it is. Cool. So case 7, 54-year-old female. She's got a smoking history, which we know is a risk factor, and she's got chest pain for 3 hours. Okay. Take a second to pause the video if you want to. Go get a coffee or a Red Bull or some methamphetamine because this is a long talk. Don't actually do methamphetamine. That was a joke. Meth is a terrible drug. But this is a very long talk. It goes for a while. And there's a lot of content to cover. So, you know, like I said earlier, by all means, pick this up at some other point. But anyway, I'm going to launch into this one. I'm assuming you're all caffeinated and amphetamine up. So we have looking at the forest, we've got some alarms, I would say. There's quite a lot of ST depression. That really stands out to me in those anterior leads. And that's probably about all that stands out to me if I'm just kind of having a glance at this ECG, but that's an important thing to stand out. So kind of going through a little bit more systematically as we like to do. Let's use red. I like that color. Can't really see the P wave. I mean, I think it's here, but it's not a big deal. We'll kind of look in lead 2 later on for a better view, hopefully. We got like a long QT, I would say. I'm not going to bother counting it. If you want to know like how to count a QT, you just kind of count from like the patient's Q wave all the way to the end of the T wave. Chuck that into milliseconds, and then like you kind of have to do some kind of complex math to correct it to rate. Just go into like MedCalc or something and type in QT correction formula. You just got to punch in the patient's QT and punch in the heart rate, and it'll tell you what the QT corrected is. I'm not going to do that today because it's not like relevant, but like as a general rule of thumb, if a T wave is like more than half of the interval between the two R waves, and generally it's probably long QT. But like, you know, I say I talk for another day. So yeah, looking at our lateral leads, I mean, looks pretty unremarkable. Lead 2, aside from that weird looking T wave, pretty unremarkable. I think these P waves are tiny, but I do think that there might be a borderline first degree AVB. It's kind of hard to tell. Actually, yeah, you can see it quite clearly here. There is a first degree heart block. Again, like a pretty non-specific finding. I wouldn't be writing in my cardiology journal about first degree heart blocks that I find. But what really does stand out is this patient has a huge amount of ST depression in our anterior lead. So in a patient with like in a patient presenting with like ACS-like symptoms and ST depression like this, I hope that we would be taking these patients to the cath lab. And it's something else that we can do that may or may not help our diagnosis of ACO-MI in this patient. And I'm sure a lot of you have already kind of clued on to what that is. Clear drawings and move on. Cool. So posterior STD. Actually, that should read anterior STD. So sorry about that. But anterior ST depression creates a challenging diagnostic and slideshow problem, apparently, for clinicians. So among 1,200 patients presenting with ACS and ST depression isolated to V1 to V4, 25% of them were found to have coronary occlusions. So that's not maybe as many as you might think. But yeah, there's some other differentials to kind of consider with this type of pattern. And one of the big ones that comes up and might come up in a minute is subendocardial myocardial ischemia. But yeah, a posterior ECG may aid in differentiating. And you can see here, a posterior has been done. So this is the same ECG from the same patient. And I think, and you can see, I mean, they've not labeled them, but this would become V7. This will become V8. This will become V9. And the issue with doing a posterior ECG, which I'm sure like anyone who's done one will notice, is that like when you attach the electrodes to the patient's back, there suddenly is a lot more tissue between the heart and the ECG electrode. You know, you've got like all of the tissue within the chest. You've potentially got the heart. Potentially got the patient's lung. And then you have like the scapula, that big bone that sort of sits at the patient's back. So suddenly to like record the electricity, there's a lot more tissue, like there's a lot more density that the electrodes have to kind of pick up. And what this like means is that the amplitude is going to be significantly lower. So yeah, that's why these QRS complexes are tiny, and that's why sometimes it's really hard to appreciate the ST changes that happens when you're doing a posterior ECG. And I think that's also why the actual like heart attack admission guidelines says like just use a cutoff of 0.5 millimeters. It's because the ST elevation is likely to be really subtle if you do a posterior. Okay, so my advice would probably be if I saw depression like this, just take the patient under high-risk ACS, query posterior MI. I mean, there's nothing wrong with that. They're going to end up at the same destination, going to be speaking to the same cardiologist, as far as I'm aware. But yeah, look, if you do the posterior, you can say it's a confirmed posterior MI, and that might trigger a slightly different response. You can take them under STEMI. So, but they're going to end up getting an angiogram either way, unless, you know, another diagnosis is made by them in the back of your ambulance, which is, you know, entirely possible. Like the previous slide said, 25% of these patients are having a posterior. So there's a lot of other things that can cause this. Anyway, I think there is some ST elevation. I think it is about 0.5 of a millimeter in these posterior leads. So this is a patient that should be going to a cath lab. Yeah, so they were found 90% occlusion of the left circumflex and peak drop was 50,000. So yes, well done. Case 8, 77-year-old female, and she's presenting with pulmonary edema. So, you know, difficulty in breathing, worse when she's lying flat, crackly chest. We should know what pulmonary edema looks like. I'm sure you've all seen lots of examples of it out on the road. It's pretty common. Here's her ECG. So of note, this patient didn't have chest pain. Just bear that in mind with our interpretation. Now, take a second to pause the video. 3, 2, 1, and go. So yeah, we've got looking broadly at the ECG. Looks cool, man. Something that like is a little unusual is like we have these kind of changing QRS morphologies here. This is like something I'm curious about, but I don't ultimately think actually like means anything in the context of this patient because like it's not really repeated. It might just be like kind of like a ectopic atrial beat that's conducting like slightly differently potentially. Sometimes you can see this cool pattern where like every second one will like have a different morphology, but it won't be bigeminy. It will still have like a normal sinus like atrial P wave before it. That's called like electrical alterns, and it means like, you know, pericardial effusion. That's a cool thing to look up. But again, I'm fully digressing. I'm sorry I keep doing that. No one's here to keep me in check. I'm just like ranting. Anyway, ECG. Lateral T-wave inversion, pretty non-specific finding. You see it a lot in patients with left ventricular hypertrophy. What does the ST segment look like? I mean, the baseline is like a little bit whack. You can see how like it's up here, and then it's like here, and then it's like here. It's like here. So like that's probably the patient breathing like quickly because they got pulmonary edema. There's probably like increased workload of the patient's rest rate and stuff. So that's potentially why like the baseline's off a little bit. And that also, I mean, it might contribute to this, although my gut tells me that that's actually probably not what's going on there. But anyway, but I wouldn't say there's any like gross ST depression in AVL. Looks fairly normal. Lead 3 is also fairly normal. AVF is okay too. Okay, and then it's like not until we kind of have a look at our anterior leads that we do start to run into a bit of a problem. So we got some depression. We got about 1 millimeter of depression, I would say. Again, it's kind of hard to exactly evaluate because the like the baseline of his ECG is a little wavy, but like we can definitely sort of like appreciate that there is some ST depression here. I hope that's clear to everyone watching. And again, you can kind of see it like here. There's like ST depression, T-wave inversion. So this is unusual. Patients not meeting STEMI criteria. They're not meeting left bundle branch or VPR because it's neither of those. Are they meeting heart attack admission criteria? No, they're not, because this patient does not have chest pain. So this patient, despite these changes, should go to local hospital. But they were not. They were taken to an angiogram. And peak troponin peaked at 6.7 nanograms per liter, which is below the cutoff for STEMI diagnosis. And all her coronary arteries were diseased, but there wasn't any obvious occlusion. And this is an example of diffuse subendocardial ischemia secondary to coronary artery disease. So what the hell does that mean? Basically, what we're talking about here is if you kind of picture the heart as a muscle which demands oxygen, and without oxygen, it will become ischemic. And if it has no oxygen, it will become necrotic, it will die. But it can still kind of function when it's ischemic. It's just sort of in pain, if you will. This is like an example of that ischemia happening. So this patient has coronary arteries that aren't occluded. There's not like a blockage, but there's disease in them. That means that there's not enough blood going to meet the demands of like the heart. Okay. And when you look at the patient's presentation of like having pulmonary edema, that could potentially be one of the reasons why we're getting these changes. Like there is a problem with this patient's lungs, but she's not getting enough oxygen. So she's not able to deliver enough oxygen to her heart to sort of meet the needs of her myocardium. And that's causing these like changes in her ECG that are suggestive of ischemia, like ST depression, but she's not infarcting. So this is not a patient that immediately needs a cath lab to kind of, save her heart. This is someone who needs, probably correction of her pulmonary edema first and foremost. And then at some point in the future, she might need an angiogram as an outpatient. And then potentially she might need some stents put in, but at the moment she doesn't need primary percutaneous coronary intubution. I hope that concept makes sense to you. So case 65. Nope, case 9. Sorry, I'm recording this at 7 o'clock. I haven't had my dinner yet. I've just come off night shifts. I know I'm making excuses, but if I do misspeak, and I have misspoken a few times already, I do apologize. So case 65, did it again. Case 9, a 65-year-old male patient with acute chest pain. Here's his ECG. If you want to pause it and have a look, 3, 2, 1, cool. So again, looking at the forest, this ECG looks very weird to me, very concerning. There's a lot going on. It looks to be sort of a sinus rhythm. I think it's regular. I'm not going to get some calipers out, but it looks broadly regular. There's a P wave before every QRS complex. I can see them best in leads 2 and V1. I do notice that he has got some very broad kind of discordant QRST complexes here and here and here. Side Coldies, like these are multifocal PVCs. So he's got some PVCs, which I think we should all know what they are. They come up very frequently. On their own, they don't mean much at all. But in the context of specific diseases, we could maybe get a little bit more alarmed about them. And they're called multifocal because they're all of different morphologies, which would suggest that they're coming from different points in the ventricle. But yeah, anyway, looking at our high lateral leads, we have looks actually pretty normal except for this inverted T wave in V1. AVL looks normal. We've got an upright T wave, we've got this PVC, but we're not going to include that. Okay, inferiorly, we have marked ST depression in lead 2, about 3 millimeters. Normal access, so that's at least one good thing this ECG has going for it. Lead 3, we got small R wave and inverted T wave and a little bit of ST depression. AVF, we got ST depression. AVR, whoa. So people kind of sleep on AVR, but I'd say check AVR out every now and again. Sometimes it's playing up. And in this case, it is playing up pretty significantly. We got like 4 millimeters of ST elevation, which is pretty substantial. But what could that mean? Well, we're going to get into that. V1's elevated as well. The baseline isn't great. It shouldn't be looking like this. If your baseline's terrible when you handed an ECG, don't be afraid to like do a few things to get a better tracing. You know, reposition your patient, live and semi-recumbent. If their chest is hairy, shave it. Like, you know, it's worth getting an ECG that you can actually make a decision about than like having a guess because of like poor tracing. You know what I mean? Like, take the time to get a good tracing. Obviously, if a patient's like clearly having an infarct, then like, I mean, like, get them to hospital, like get them to PCI. That should like be the #1 thing on your agenda there. And try and get some good tracings en route if you can. But like, if you can't and you got that like clear pattern, that means they're indicated. Like, you know, just get them to hospital. But like, if you're like, you know, you can afford to take your time, like try and get a high quality ECG. Makes the rest of this like a lot easier. But anyway, moving on, digressing again, we got yeah, pretty global ST depression. Some of it's quite substantial. Good R wave progression, but anyway, so what does this all mean? ST elevation, AVR, global ST depression is what I kind of described as of multifocal PACs. So traditionally, this has been associated with, and what I was taught, left main coronary artery disease, or occlusion rather, or triple vessel disease, or rate-related endocardial ischemia. And that's still more or less this what this pattern represents, with some caveats. So ST and AVR, it's commonly correlated with LMCA occlusion, so left main coronary artery occlusion. That is your big coronary artery that divides into your left anterior descending and your left circumflex artery. The actual incidence of like proximal LMCA occlusion is low. And the reason for that might be pretty obvious. It's a huge artery. It supplies like almost all of your left anterior and left posterior ventricle. If that gives up, like, and you don't have good like collateral circulation, like you're dead, 100%. So like the chance of this artery being completely occluded in a patient that's sitting up and talking to you is pretty low. But if they not settled did a study where they did kind of look at all of the patients who presented with ST elevation in AVR, and they found an obstruction rate, which they defined as greater than 50% stenosis of 23%. So if you see this pattern, about a quarter of your patients probably have a significantly diseased LMCA. And this pattern is probably more commonly associated with like non-occlusive OMI, so non-occlusive obstructive myocardial infarction. So like occlusions that haven't fully compromised blood flow to a coronary artery, or we can see this pattern a lot in patients who have multiple vessels that are very diseased, but none of them are included, which is triple vessel disease. And it kind of represents that this patient has really diffuse subendocardial ischemia, which I think is a concept we talked a little bit about in a previous slide. So this is the angiogram taken for patients, like the patient whose ECG we just saw. This is taken from their angiogram. And we can see here that there is really severe disease of that really proximal left main. But there is still blood flow. We can see, I think this is our LAD, I think this is our circumflex. I might have that the other way around. Again, I'm not a cardiologist, but we can see that these veins are getting blood to them, which is great. And like I said, if this was completely stenosed and none of these veins were getting blood, this would probably result in sudden cardiac death. But what this would suggest to me is that if you do see this pattern, and I haven't kind of written it down here, but from some of the reading I've done, if you see elevation in V1 as well as in AVR, it's more likely to be disease of the left main. So if you do see this pattern, take them under high risk ACS, man. Like, these patients need to be in a cath lab. These patients need angios. 99%, that's like an impending 100% stenosis, which is going to kill this patient. So, like, yeah, get them to a cath lab. You can take them under high risk ACS. It's not a problem, except in some cases. 75-year-old female patient, 3 days of palpitations, dizziness. Again, of note, she doesn't have chest pain. Okay. Sorry, I was just making sure that it's still recording. If you want to take a pause, pause now. If not, I'm going to drink this water and then we'll start interpreting. A lot of talking. Pretty sick of my own voice. Okay, so yeah, looking at the forest, things seem off. The main thing that seems off is this is irregular, which, you know, should prompt you to look for P waves, and I do, and I don't see any. So irregular rhythm, no P waves. I'll give you 3 seconds to come up with a rhythm. 2, 1. Atrial fibrillation, or rapid atrial fibrillation in this case. Again, we can do that little kind of test, and to be fair, this test is broken as hell when the rates are regular. It's only really works when they're regular. But let's just pick an average looking RR interval in this ECG. I'm going to go with this one. So go about 300, 150, and a little bit extra. So that's probably, that was kind of garbage. Let me try that again. Let's try it again on one that kind of lines up on the dot. This one does. It's probably a little bit longer than some of them, but yeah, so this would be 300, 150, 100. So rate for this is probably between 100 and 150, and it's irregular. So it's tachy. So it's fast AF, or atrial fibrillation with rapid ventricular response rate is the wordy term. Okay. So that's an important rhythm to identify. And then we're going to kind of move forward and we're going to look at lead 1, and we notice an inverted T wave. Again, that's not terribly specific. These lateral inverted T waves can be suggestive of left ventricular hypertrophy. This patient doesn't actually meet the voltage criteria for an LVH diagnosis, but ECG is pretty shit at identifying LVH in the first place. But it could also represent ischemia, as we kind of talked about before, especially if it's associated with some ST depression, which it is in this case. Okay, so then kind of looking forward, at our inferior, we have this very kind of a bit of a weird looking QRS complex. We got like an RSR. I think that's what that is. And then like we do have like kind of like a upward sloping, almost isoelectric T wave with some marked ST depression. Cool. And we have the same thing in lead 3. And AVF. And then we kind of look at our AVR, and what do you know? It's elevated again. And then we have our V1 that's got like a tiny bit of elevation, but not a lot. And then we got depression, 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 inversion, depression, inversion, as we've already talked about. Okay, so I mean, you could look at this and you'd be like, oh, okay, we just talked about this. This patient has elevation in AVR and a little bit in V1, and they've got that widespread ST depression. This must be disease of the LMCA or something. And yeah, you could be right, but if we sort of remember some of the other differential diagnoses, and we kind of factor in that this patient is presenting without chest pain, remember, is very clear, is very key. They just have palpitations and dizziness. That, you know, would not qualify this patient to go to a heart attack center as high-risk ACS, okay? Because to go under that, they need to have kind of symptoms suggestive of ACS, being sort of chest pain. Palpitations is not suggestive of ACS, okay? But in this case, the cath lab was activated prior to rate control. Rate control is when you give a patient with fast AF medication, like calcium channel blockers or beta blockers or digoxin. I'm not exactly sure what the protocols say, which one comes first. But there's kind of like two strategies with AF. They either try and slow down the rate, or they give an antiarrhythmic, like, I don't know, amiodarone is an example of a pretty severe one. There's other ones, and they try and convert it back into sinus rhythm, or they can like cardiovert electrically. And I've written rate, yeah. So cath lab was activated prior to rate control. No obstructive lesions were found. Troponin was negative, and she spontaneously cardioverted, which means that she just switched out of AF and into sinus rhythm. So this is something that can happen in patients who suffer from paroxysmal AF, which is just means that they flip in and out and probably will need an ablation at some point, so they don't have a stroke. And yeah, this was her ECG post-rate control. And we can see that in this ECG, a lot of these changes that we've commented on, including like the inverted T waves in one and AVF and down here and the ST segments, have all kind of normalized, okay? So what was happening in this patient's case? Remember when we talked about the heart as being kind of like a muscle that requires oxygen. Without oxygen, it will become ischemic, and with ischemia, it will demonstrate that kind of pattern of elevation in AVR and global ST depression. What's happened in this patient's case is they've been in an arrhythmia, fast AF, which has a high rate. So the heart's beating really, really fast. And the heart's beating fast, it requires more oxygen. But this patient is not able to get enough oxygen to the heart, probably because they're old and have poor coronary arteries or poor circulation or whatever. I mean, she had no lesions in her coronary arteries that were obstructive, but it doesn't really comment on the status of them overall. And what this is causing is it's causing that pattern of like subendocardial ischemia, okay? Okay, cool. So moving on to case 11, we have a 60-year-old male, and he's presenting with acute chest pain, and he's got a history of left bundle branch block, okay? So looking at the ECG, we've got a pretty big clue, I guess, starting off the bat, in that we know that this patient has left bundle already. We can kind of look to our ECG to confirm that. And left bundle was something I personally struggled, like left and right bundle was something I really struggled with for a little bit when I was sort of starting out with ECGs. But like the basic way I would kind of look to remember it now is that we have a QRS duration that's, you know, greater than 120 milliseconds, or 3 little squares. So in this case, we've got 1, 2, 3. So we're greater than 120 milliseconds. So it's a broad complex. And then we look to V1. And in left bundle branch block, V1 is going to be predominantly negative. There's going to be either a dominant Q wave. So if we think of our ECG, and that's our Q wave, and our S wave, the Q wave is going to be dominant, or we're going to have a dominant S wave, like here. So we've got a small R wave and then a really dominant S wave. And either way, the QRS is going to be predominantly in the negative direction of V1, V2. And that's what we have kind of going on here. And then there are some other sections to the left bundle branch, kind of like diagnostic criteria, where we kind of look for, like, you know, prolonged R wave peak time and R wave notching and those sorts of things. But to be honest, I usually have to look those up if I'm trying to get really technical with it. But if I see these things together, that generally tips me off that, you know, and the ECG has this type of morphology, it tips me off that this is likely to be a left bundle. And left bundle presents like a really interesting problem when we're kind of thinking about trying to diagnose STEMI, because as you will have noticed if you've looked at a lot of left bundle branch blocks previously, they have these really atypical or like unusual morphologies to our normal ECGs, where we have these discordant kind of QRS complex and T-wave sections. And what I sort of mean by discordant is that the QRS complex points in one direction and the T-wave points in another direction. And when we see this in the context of left bundle branch block or even right bundle branch block, we often get ST elevation. So most, if not all, left bundle branch blocks are going to have a degree of ST elevation as part of that sort of normal physiologic ECG. And that's why it gets really difficult to kind of diagnose STEMI in the settings of these patients. It's one of the limitations of using STEMI is that it really doesn't work with left bundle branch block because these patients are going to have ST elevation already. So what can you do? Well, fortunately, there is sort of a set of rules, and we'll kind of go through them quickly now, and then we'll sort of revisit some of the literature behind them in some of the coming slides. But really central to kind of like diagnosing MI in the context of left bundle branch block, or at least recognizing ECG findings that are suggestive of MI, is that kind of central concept of discordance and concordance. Okay, so we're going to go through that, and I'm going to really try and make sure that we kind of get that into our heads, because understanding that is going to be really central to understanding how we sort of spot MI in these patients. So if we like look to V2, we've kind of been through this already, but this is an example of kind of like a discordant QRS and T-wave section, right? Because we have our QRS complex going one way and we have our T-wave going the other way. Okay, so this is discordance. Let me type it. So we also have in left bundle branch block, or we can have what's called concordance, okay? And concordance is when the QRS complex and the T-wave are both heading in the same direction. They're concordant with each other, okay? And if we kind of like take some time to try and spot the concordant leads here, we've got quite a few leads where we've got some concordance. For concordance, I think I spelled that right. I could be wrong, but in lead one, that's here's an example of concordance, because we have an R wave, an S wave, and then an R prime here. So we have and then we have a T wave that's kind of pointing in the same direction. So both our QRS complex and our T wave are both pointing in the same direction. That means that they're concordant with each other, okay? Now, these are like kind of tricky to get your head around at first, but like once you kind of understand how these concepts work of concordance and discordance, we can begin to look at like, you know, patterns that are really concerning for MI in these patients. So there's three kind of traditional rules that we're going to talk about. And this is kind of getting into modified Scala-Bosa criteria. Now, the first one is we look for our concordant leads, and we look for any ST elevation in any leads that are concordant, okay? So ST elevation in concordant leads is really concerning that the patient could be having an MI. And if we kind of look at this lead here, and we kind of consider that, you know, we've got concordant QRS complex and T-wave, and we look at our isoelectric line, we can see that, oh, okay, we got about 2 millimeters of concordant ST elevation in lead one. And if we look at lead two, which is also, I mean, I'd say the QRS complex is more or less isoelectric here. But it's still kind of, you can probably generally consider this concordance. I'd say it's a little bit more borderline, but there is quite clear sort of ST elevation of about 2 millimeters as well. And then again, AVL, same story. We've got concordant, we've got kind of, again, like a bit of a biphasic T-wave going on, but we've got more or less T-waves heading in the same direction as QRS complex, and we've got 2 millimeters of ST elevation. Same again here in V5, same again here in V6. So this is our first rule. Any lead at all, and it only has to be one lead. We don't have to be looking to confirm this in multiple leads. Any lead at all with concordant ST elevation should be really concerning for MI in left bundle branch block, okay? Now, we can also have concordant ST depression. And I don't really see any of that on this lead. I mean, on this ECG, but if we have concordant leads, so say that, you know, in V1 to V3, say that we had a Q wave and a T wave that were heading in the same direction, but our ST segment was depressed. I'm really sorry for my drawings, they're terrible, but I hope you get the idea. In V1 to V3, this is another one of Scarbosa's criteria, and this would be kind of considered to be really concerning for MI as well. And the final rule, when we look at Scarbosa, is one of excessive discordance. And what is meant by that is that we have discordant leads. So QRS complex and the T wave are heading in different directions to each other, but there's an excessive amount of ST elevation that is not proportional to the size of the preceding QRS complex. And that's defined as anything that's kind of greater than 25% of ST, so ST elevation greater than 25% of the preceding S wave. Okay, so I appreciate that probably doesn't make a whole heap of sense. So what we'll do is we'll kind of go through it. So this is our S wave here, because we have our Q wave, which this one doesn't have, our R, and then we'd measure our S wave down to here. So our S wave would be about 5, 6, 7, maybe 8 millimeters. It's kind of hard to tell, to be honest. And then we have our ST elevation here, and we can count that out. We can go 1, 2, 3, 4 millimeters. Now, I'm sure a lot of you are better at math than I am and can probably do this in your head, but I am shocking at math. It is by far one of my weaker areas. So I'm going to have to use a calculator, which you can't see, but basically all we're going to do is divide the ST elevation by the length of that preceding S wave. So we're going to divide 4 divided by 8. And that equals 0.5, which is 50%. Okay, so it equals 50%. And that's greater than 25%. Okay, so we would say that this is excessively elevated in the context of the preceding S wave. Okay, so this is another thing that would clue us in that this patient is having an MI. Okay, so I definitely appreciate that that's a heap of information to kind of take in. And it's really not going to make sense with one ECG. This is the type of thing that's going to take a lot of kind of like ECGs to look at before it will start to click. But just something to be aware of and something that you can kind of look up on your phone if you've got a patient with left bundle branch block. You can look up Smith modified Scarbosa and you can kind of run through that and you can kind of look out for these, you know, red flags that this patient could be occluding. Okay, but that's it in a nutshell. So in this instant, this was a pre-hospital case. This patient was taken directly to a heart attack center and they were found with a proximal LAD occlusion. So that's fantastic. Great. So as we've kind of talked about a little bit already, left bundle branch block can really complicate the detection of occlusive myocardial infarct, as these patients are going to present with that discordant ST elevation. All right. And Smith modified Scarbosa criteria is currently the best tool that we have at identifying NOMI in the presence of left bundle branch block. Now I say currently because there is some other emerging evidence that we might talk about in a little bit, but I don't want to kind of overwhelm you, so we'll just focus on the Smith modified Scarbosa. Okay, so the criteria we went through it on the previous ECG, but it is as follows. It's concordant ST elevation greater than 1 millimeter in 1 lead or more. It's concordant ST depression greater than 1 millimeter in 1 lead or more of V1 to V3. And it's proportionately excessive discordant ST elevation in 1 lead with greater than 1 millimeter of ST elevation, as defined by greater than 25% of the depth of the preceding S wave. So I think if you kind of like read that and you have no kind of context as to like kind of what any of that means, or you don't have an ECG in front of you, that's really hard to get your head around. But I hope that if you kind of like, you know, revisit how we just broke down that previous ECG, this can actually start making sense to you. Okay, but I do appreciate it's really confusing. Okay, moving on. So here's the rule. And it's basically kind of like what we just talked about. And you can see here that the sensitivity and the specificity is actually really high. Now, I do want to kind of focus a little bit on some of the literature that like supports modified Scarbosa criteria and sort of where it's come from. So I'm just going to kind of get my notes on the papers up. I know that you can't see them, but we'll talk about them. Scarbosa criteria. Cool. So it was first created by Elaine Scarbosa in 1996, and it was modified by Dr. Stephen Smith in 2012 to create what's now known as sort of like the Smith modified Scarbosa criteria. Now, the original paper that kind of looked at modifying the Scarbosa criteria, the 2012 paper, I just wanted to bring everyone's attention to the fact that like it was across 3 different institutions, and it only looked at kind of 33 patients who had left bundle branch block and who had angiographically confirmed like MI. And then there are 129 patients in the control group who had left bundle branch block, had ACS-like symptoms, but weren't having an MI. Okay, so it's not the biggest cohort. And that was the study that they used to kind of create these rules off of. Okay. And they did do a validation study. They kind of followed it up with another study in 2015. And in this one, they did have a slightly larger cohort where they had 45 patients who presented with angiographically confirmed MI and left bundle branch block, and they had 258 in the control setting. And that's where that sort of sensitivity and specificity kind of comes from. That's reported on in the NOMI manifesto, okay? But I just want to bring people's attention that these aren't the hugest samples of patients. So this might be over or underestimating kind of these numbers here. And we do need kind of like, you know, more research, like with a lot of this stuff to really like validate these findings, okay? But yeah, I hope that makes sense. So something else I want to talk about quickly before we move on is that there might potentially be an easier way to interpret this, okay? There's a fairly recent paper that's come out in 2020 out of Spain, and it's called the Barcelona algorithm, because of course it is. And it's sort of building on that kind of information from the modified Scarbosa criteria. They're basically putting their own take on it. And I wouldn't bring it up because I appreciate I'm really cognitively overloading at the moment. But they had a bigger sample size than the validation sample for Smith modified Scarbosa, which is pretty cool. They had 163 sort of patients in the kind of original study they did to create these rules, and they had 107 in the validation cohort, and they had 214 kind of control patients. And they kind of came up with their own set of criteria, which is really similar to the Smith modified Scarbosa, but it's actually a little bit simplified. And in theirs, they said that any ST deviation in concordant leads is considered abnormal. So what that's doing is it's kind of combining those, like if we look here, it's kind of combining these first 2 rules to say that like actually if the lead's concordant, so like if we have a QRS and a T wave going in the same direction like this, it's concordant, then any degree of ST deviation greater than 1 millimeter, so either depression or elevation, is considered abnormal, okay? In any lead, not just V1 to V3, like Smith modified Scarbosa criteria says. And that's cool because that makes it a little bit simpler, right? You don't have to kind of think about, oh, well, depression V1, V3. You can just look for any concordance and any ST changes, okay? And then instead of having this whole kind of concept of excessive discordance combined by an STS ratio, they simplified that as well. And they just said that if there is discordant leads, where the QRS complex and the T wave are in kind of opposite directions to each other, but the amplitude of the QRS complex is 6 millimeters or less, like it's low voltage, because, you know, if we kind of like go back and we look at our typical left bundle branch block here, we'll see that usually like the QRS complex is quite, you know, like large in voltage, but if it's low voltage like this one and it's less than 6 millimeters and we have more than 1 millimeter of ST elevation, then that's concerning, okay? So it's very similar rule. I've kind of just used like a different way of like thinking about it, okay? So yeah, again, like promising, and with their modifications, they kind of reported sensitivity and specificities were over 90%. I'll just get them up for you. Yeah, sensitivity of 93% and specificity of 94%. So they're really good numbers. But again, needs more research, needs more longitudinal kind of validation. But like promising stuff, and interesting space to kind of keep an eye on. But I think like the main principle that all of this research is talking about is kind of that concept of like, you know, concordance, ST deviation in concordant leads in left bundle branch block is really alarming. Okay. And then that kind of excessive discordant, and there's different ways to sort of define that. Appreciate this is a lot of information and a bit of a cognitive overload, but I hope it's kind of making some sort of sense. All right. But we're going to move on. So case 12, we have an 82-year-old male. He's got a dual chamber pacemaker and he's got sudden chest pain. All right. So now that we've kind of been through that previous chat about, you know, modified Scarbosa and the Barcelona algorithm and stuff, I'll give you a second to pause this presentation, have a look at this ECG. I'd really encourage you to try and find out what's potentially going on here, kind of keeping those rules in mind. And I'll give you a big clue that the same kind of concepts that we use in left bundle branch block can be used in ventricular paced rhythms. Okay, so take a pause, see if you can figure out what leads are problematic, and then we'll go through it together. Okay, so 3, 2, 1. All right, so ventricular paced rhythms, you can tell this is VPR because we do have these like lovely pacing spikes. Now these won't be visible on the LAS HAC 15 that we use in the LAS. The algorithm that kind of, you know, prints the ECG removes these pacing spikes, and instead it will kind of indicate that it's a paced rhythm by having like a little arrow underneath. But that's cool. Because, you know, it effectively just means the same thing, but we've got our pacing spikes here. Looks like they're coming fairly regularly. I mean, we have a kind of like an ectopic beat here that sort of offsets it a little bit. And we do have some P waves that seem to kind of be marching through without too much regularly. So maybe like the underlying rhythm here. I'm not sure if that's a P wave actually, disregard. The underlying rhythm here might be like a complete heart block, and that might be why this patient has a pacemaker, but I'm sort of just speculating here. But anyway, it's not what we're looking at. What we want is we're looking at that kind of concept of concordance and discordance, okay? And I'm just going to take the simplified sort of Barcelona approach to this ECG because I think it will, I think it's a little bit easier to sort of follow. So let's just start by going through our leads and looking for any concordance, okay? So this is discordant, AVL is discordant, and we'll go inferior is discordant, 3 and AVF are all discordant. Remember our QRS complexes and our T waves are facing the wrong way. They're facing away from each other. V1, okay, I think that is concordant, but the ST segment kind of looks fine. V2, discordant, and we have a lot of ST depression, but we'll kind of come back to this. This does look strange though. Similar thing in V3. Similar again in V4. Okay, and now we are in V5. And this is where I'd say these leads are, it's a little borderline, but I'd say that we do have like some concordance here because the QRS and the T wave are like, I mean, the QRS is kind of isoelectric, but they're more or less pointing in the same direction. We do have some quite marked ST depression. So if we're going by the Barcelona algorithm, this patient would be, you know, positive at this point and would be concerned about having an OMI, particularly, you know, with the history that this patient has of having like ACS-like symptoms, okay? And again, we have some concordance here and we have a little bit of ST depression in V6 as well. Okay, so let's revisit lead V2 for a second as well. So if we remember from sort of the Barcelona algorithm, we have that kind of concept of like, if we have low voltage QRSs and we have like greater than 1 millimeter of ST deviation, that's really alarming, right? Well, what do we have here? This QRS complex is low voltage. It's 6 millimeters exactly. And we have 3 millimeters of ST depression, of ST deviation. So V2 again is like a positive finding that this patient is likely having an NOMI. And this is greater than 6 millimeters, so I don't think we can quite apply it here. But anyway, so we've got a few like concerning red flags here in this ECG. So yeah, this is the kind of person that if they're presenting with ACS and you see an ECG like this, you should really be going to the cath lab. And if you do see an ECG like this in an older patient and they're saying, you know, maybe they've got some non-specific chest pain, but you're kind of picking out these changes, I think that should really hopefully prompt you to kind of like dig a little bit deeper and really try and tease out some of those symptoms of ACS from your patient so that you can justify taking them to the cath lab under that left bundle branch block VPR sort of pathway. Because these are patients who are, you know, on the sort of balance of risk, likely to really benefit from having some angiography early. But cool. I hope that concept's making sense to people. It's a lot to get your head around, but you know, well, you'll get there eventually with enough practice. I can guarantee it. So yeah, scarbosa can still be used in VPR, albeit with reduced sensitivity. And this patient was found to have a completely occluded posterolateral without RCA. So sensitivity drops down to 67% of scarbosa. Now, interestingly, the Barcelona algorithm, which is the one I use to interpret that ECG, hasn't actually been validated for VPR. It's just for left bundle branch block. So there's no actual recorded sort of sensitivity or specificity in how that sort of works with VPR. But considering like the physiologic similarities and kind of how those ECG rhythms look, I would sort of wager that you could apply the same sort of rules to VPR. But again, and like with a lot of this stuff, really want to emphasize that we're using these rules to kind of, you know, include patients, not exclude patients, because a lot of this is still like it's emerging literature. These are emerging areas of study. And, you know, these aren't like completely established sort of rules and need more sort of research to keep giving us more insights into how we can use them. Okay. But I think this kind of central concept of excessive discordance and concordant ST deviation is really important for sort of recognizing occlusion in these patients. Okay, moving on. Case 13, 40-year-old male patient presenting with a history of chest pain that's now resolved. And he wants to follow up with his GP in 8 hours' time. And here's his ECG. So I'll give you a second to interpret it. 3, 2, 1, cool. So yeah, first thing when I'm kind of looking at the Forest-Swiss ECG, the tracing's kind of shoddy. You know, like if I'm looking at these sort of like limb leads over here, I can see there's a lot of artifacts. It's quite hard to determine, excuse me, exactly what the rhythm is. And I think like in this case, don't be afraid to, you know, try and get a better trace, as long as it's not sort of delaying treatment for this patient. But anyway, so that's one of the first things I noticed. And everything else kind of looks okay, although there are these sort of strange biphasic T waves, which we're going to kind of come back to, I think, in a little bit. But anyway, kind of then looking at the trees, lateral leads look fine. Inferior leads look okay as well. ABR is normal. And then we're going to look at our precordial leads, and that's when we sort of do notice that we have these biphasic T waves. And I hope you know what I mean by biphasic. Basically, it just means that the T wave is going in one direction and then it's going in the other direction. That is biphasic. Bi means two, and phasic, I guess, just means phases, I assume. But yeah, cool. So we have these biphasic T waves, and these are really unusual. But unless you kind of know what these mean, it's going to be really hard to sort of make a decision about what to do with this patient. So, so this is like an example of Wellens. Specifically, this is Wellens type A. So Wellens syndrome is seen in patients who have had an occlusion and then have had, for whatever reason, like reperfusion to that like ischemic area of heart. So it's an indication that the patient has like critical stenosis of that coronary artery, of the left anterior descending specifically. Okay. And it's like a reperfusion pattern, this kind of biphasic of these deeply inverted T waves that you get with Wellens type B. And it's interesting because in patients who do receive reperfusion, like patients who get thrombolized or patients who, you know, can have PCI, sometimes you might see like a Wellens type pattern when they do get blood flow sort of restored to that LAD. But basically, you know, what this pattern means, particularly in the context of a patient who's had really crushing cardiac chest pain and has maybe chilled out a little bit, and now it has like chest pain that's a lot less severe, that would suggest that, and you see this ECG pattern, that would suggest that, hey, this is a critically diseased LAD. This is imminently going to be occluded, and this patient should go to a cath lab. And you could take them under high risk ACS if they still had any persistent symptoms of ACS. Okay. So under sort of them having like inverted T waves in 2 or more leads. Okay. So again, if you see this pattern, really kind of dig for those, hey, do you still have any sort of chest pain? Are there, you know, reasons that I can take you under that high risk ACS pathway? Because these are patients that are going to kind of occlude imminently. But yeah, it's a cool one to be aware of. So biphasic or deeply inverted with like a little bit of ST elevation is kind of what the Wellens type B looks like. But yeah, I hope that sort of makes sense to people. Oh, that was it. Cool. This is an older version of the slides. I decided to de-LAS it a little bit, just because I was uploading it to YouTube, and although I will make it sort of like shared link only, I didn't want to have like the LAS emblem all over YouTube and such. Thank you very much for bearing with. I appreciate that was a heap of content, and thanks for sticking through it. This is the first time that I've done anything like this, so I would really appreciate some feedback. I will attach a link in the email that this kind of link to this video is in, with like a survey where you can kind of offer some thoughts, and as well as kind of like offer some thoughts on some future CPD. If you find like talks like this to be helpful, if you found that this was useful in any way in informing your clinical practice, please let me know. It'll encourage me to make more videos like this. If I don't hear anything back, then I'm probably going to be less inclined. I'm really passionate about CPD, and I really want to kind of, you know, give people the opportunity to learn and to grow, and create the kind of CPD that I wish existed when I was, you know, starting in paramedic practice. So yeah, please give me as much feedback as you can. I appreciate you've already given me a lot of your time by sitting through my rambles here, but yeah, that would be greatly appreciated. But thanks for sticking with me. If you do have any questions about any of the content covered, or you would like to see full references for any of the papers that I talk about, if you're having trouble finding them, I do have copies of them all, and I'm happy to send them out. As well as other source materials on kind of learning ECGs and that sort of thing. Please let me know. And if you are one of those people, which is probably going to be most of you, who's feeling kind of like overwhelmed by this content and thinking that it's an impossible amount to kind of like sink in, that's fine. That's completely cool. Actually, I think I would, if someone gave me this talk. Just remember that, like, I'll reiterate the start of this whole presentation. I'm not an expert, and you're not an expert, and we're not expected to be experts. And one PowerPoint isn't going to make you an expert. But I think if you, you know, you can keep an open mind, and you keep your eye open, and you stay humble about your own kind of knowledge, and you study, and I would really recommend that you never stop studying. Life in the Fast Lane provides a really excellent library of ECGs that you can kind of go through and quiz yourself on. And if you get into a habit of doing that regularly, like, you know, once a day when you're on the toilet or on public transport, I have no doubt that you're going to reach like a near expert knowledge of ECGs at some point in your career. So, you know, don't stop trying, don't stop studying. But yeah, thanks for bearing with, guys. I've sourced all of the clinical cases that I've talked about from these websites. If you do want to improve your knowledge of ECGs, then I think these are the best online resources to do so. They all provide case reports. I think Life in the Fast Lane particularly is probably the best one. They provide case reports that allow you to kind of view them, make up your own mind, and then view their interpretations and results. And then they often include like angiographic and electrophysiologic data about the patients, which is really helpful. Dr. Smith's ECG block is, again, awesome. I think if I had one critique of it, he comes across as a little cowboyish in some of his interpretations, but he's a pretty clever guy, so I think he's earned that right. He's also heavily involved in publishing a lot of the research that we've talked about in this presentation. So I think he does have a slight bias towards the way he interprets sometimes, but I still think it's an excellent resource, one that's very well worth checking out. And I'm personally a huge fan of his. And Emergency Medicine Cases is a Canadian website, but again, has a lot of really excellent cases and excellent discussion points about some ECGs. So if you are inspired at all to go on and develop your interpretation skills, I really recommend checking out these websites and checking them out regularly, because spaced repetition, as literature has demonstrated, is the best way to learn, hands down. Cool. Here's the academic references. I'm not sure that this list is completely up to date. I think I've forgotten to include the Barcelona study in there, but what I'll do is I'll make sure I chuck that in before I kind of go live with this. I'll attach a copy of all of the slides to the PowerPoint, to the email that I send out, as well as a link to that survey, which please fill out. But yeah, thank you for bearing with, guys. I really appreciate it. Hope you have a good rest of your day, and I'll see you around.